in this slide, I can hear someone there. Please close your
Sorry, by
microphone.
accident. I forgot to close it.
Okay, thank you. So we can see here that if the fracture is in between the insertion of the pectoralis major muscle and the deltoid muscle, then the proximal fragment will be displaced in adduction, because the pectoralis major muscle is more powerful than the deltoid muscle. And if the fracture will be below both insertions of the muscles, then because the deltoid will be more powerful, the proximal fragment will be in abduction, and the distal fragment will be ascended by traction of the muscles of the arm, so biceps and triceps. So in this second situation, we'll have a longitudinal displacement which will be very important and will lead to the shortening of the arm. The mechanism of these fractures may be direct, like a direct blow at the level of the arm, or non-direct, a fall on the hand with the elbow in hyperextension, or let's say a mechanism which is quite peculiar to this type of fracture is the game of Skandenberg. You probably heard about this, when two persons try to find out who is the most powerful of them. So, and finally, in some situations that may end by a fracture of the humeral diaphysis. So it's a mechanism of torsion. In fact, that's the main mechanism in this situation. And we can see here that in this mechanism, you usually have a spiral fracture of the humeral diaphysis. Classification of these fractures is also done according to the AO classification system. You can see here group type A, type B with 3 fragments, type C with more than 3 fragments, which are the comminuted fractures. And I don't insist anymore on this classification system because we have already discussed about it. The clinical examination will show, of course, like usual, pain and physical disability. And here, there's an image I wanted to show you many times, and I told you, in fact, that it is somewhere in my slides. This is the so-called humble position, where you can see how the patient comes to the emergency room with his injured upper limb supported by the other hand in order to self-immobilize the fracture site. Well, the clinical examination will show us local swelling. Also, the examination is done in comparison with the other side. A late ecchymosis, which I have already mentioned, which is a clinical finding in probably all the fractures. Also, we hear crepitation at the level of the bone, and non-transmission of the articular movements of the neighborhood joints. So peculiarly in this side, example, in fractures of the diaphysis, if the patient will try to abduct his arm, that will be practically impossible because he will be able to abduct only the proximal fragment, and the other one will come into an angulation position with the first one because of gravity. So the elbow will not be able to follow the abduction of the proximal fragment. This is also a sign of a fracture at this level. And, which is very important, also we need to check the pulse at the level of the radial artery and we have to check the integrity of the radial nerve. That by checking the mobility of the hand and, like I said, the sensitivity at the level of the skin. The most frequent complication that may accompany a fracture of the humeral diaphysis is the palsy of the radial nerve. Well, in this drawing, and also in this drawing especially, you can see the anatomy of the nerve and especially its relationship with the humeral diaphysis. The nerve passes from medially towards laterally on the posterior aspect of the middle third of the diaphysis. So when a fracture occurs at this level, we may get a lesion at the level of the nerve. In order to check the function of the nerve, we will invite the patient to do the extension of the hand on the forearm, or the abduction and extension of the first finger of the hand. So that will be impossible because the palsy at the level of the muscles in the posterior region of the forearm. If you remember from anatomy also, the motor branch of the radial nerve is responsible of the innervation of the posterior and lateral areas and muscles of the forearm. So they will be in fact non-functional, so that's why the patient will not be able to do the extension of the hand, and will be unable to do the abduction and extension of the first finger of the hand. Besides like usual, the first examination that we need will be the X-rays, the anteroposterior view and lateral view, in order to diagnose precisely the fracture. And besides that, we'll need sometimes a CT scan if we have a comminuted fracture, or an MRI if we have a complication at the level of the soft tissues around the fracture site. Well, the evolution of this fracture is usually towards union. These fractures usually unite easily, and the full union of the fracture will occur in 3 to 4 months, and the primitive callus will usually occur about 4 to 6 months. In the orthopedic treatment of these fractures, it's very important to obtain a very solid immobilization of the fracture site in order to get the union. In order to obtain this consolidation, we may use this union, we may use different types of immobilization. One of them is this one you can see here. We'll use a splint, a U-shaped splint, which will start from the anterior aspect of the arm, then it will bend on at the level of the elbow and will ascend back on the posterior aspect of the arm, and so it's a sort of U-splint that will contain the arm, and also this splint will be applied with the help of a bandage. So this is one possible immobilization. The other one is this one, which is a cast, like you can see here, which contains the shoulder joint and the elbow joint. This kind of immobilization is usually very solid. So from the point of view of immobilization, is a very good device, but it's accompanied by complications at the level of the neighboring joints, especially the shoulder and the elbow. The elbow especially is a joint which is very sensitive to immobilization and gets stiffness. That's why in our days, these methods of orthopedic treatment have been more or less abandoned because we prefer by far the surgical treatment. The surgical treatment consists in the type of fixation depends very much on the complications at the level of the fracture. So if we have a radial nerve palsy, then sometimes we may need to go into the fracture site and to explore the nerve in order to be sure that it's not interrupted. Uh, Prior to this surgery, we may also uh, investigate the nerve by doing an electromyography. And electromyography may show us if the nerve is interrupted or has only a functional temporary damage. So if the nerve looks to be interrupted after electromyography, then we may need to go into the fracture site. And if we explore the nerve, then in this situation, we can also do an open reduction and fixation using such kind of plate with screws. And it's mandatory to put 4 screws in every fragment in order to achieve a very good immobilization. This open reduction has the disadvantage, like usually, that it evacuates the hematoma at the level of the fracture, which is unfavorable for the union of the bone. In most of the cases, the statistics showed us that the function of the radial nerve is, if it was damaged after the fracture, is an about 85% reversible. So knowing that the function of the nerve is reversible in 85% of the cases, then we usually prefer not to go into the fracture site, but to achieve a close reduction by external maneuvers, and then an intramedullary fixation by using ender nails, like you can see in this slide, or using an intramedullary rod, which will be locked in the proximal fragment and also in the distal fragment. The locked nail, the close reduction and fixation with the closed nail is the golden standard for surgical treatment of these fractures. If we have an open fracture, which is quite rare because the humeral diaphysis is surrounded by muscles, so it's quite a long way, let's say, for the fracture to open. So, but anyway, if this happens, because of course there are situations when we may have an open fracture, then of course, we need to use an external fixator, the same type that we have already mentioned before. This is another type of fixation, external fixator, the Lizarov. Well, this is Russian. Uh, One of the contributions of the Russian orthopedics to the modern science, yeah. This external fixator has the advantage that it shares the forces at the level of the fracture site all around, all around the bone, so on 360 degrees around the bone, which is very important for the bone union. Well, that's only for your information. There is no need to make a fact of this. Here is, like you know, already know because I have told you, this is the aspect of the hand in the palsy of the radial nerve. It is so-called the dropped hand because the patient will be unable to do the extension of the hand on the forearm. Complications of this fracture, the late complications may be like the non-union. Non-union may be due to insufficient immobilization or insufficient fixation by osteosynthesis. If, for example, we use a unlocked rod, or if we use a plate which has less than 4 screws in every fragment, we may get a non-union. Also, we may get quite often, especially in the orthopedic treatment, the malunion, so because we cannot achieve the anatomical reduction. Fortunately for the upper limb, so for the humerus, healing with a certain degree of angulation, of shortening, will not be damaging very much the function of the upper limb. In comparison with the lower limb, you will see that in your next lectures. In the lower limb, if the healing in the femur, for example, will be obtained by shortening of the bone or angulation, that will be very disabling for the function of the lower limb. Other complication may be the infection at the level of the fracture site. Whenever it's done by iatrogenic reasons, so during surgery, or it's because of an open fracture. And finally, we may get the so-called late palsy of the radial nerve. So that's something that may happen sometimes in the orthopedic treatment. So the patient didn't have a palsy of the radial nerve from the very beginning. That happened only after about 6 to 8 weeks during the treatment. What happened? The radial nerve was incorporated progressively in the callus and compressed, of course. So his function will progressively diminish. So in this situation, when we get such a complication, we need to go into the fracture site and release the nerve from the callus in order to restore its function. Okay, let's move on to the distal epiphysis of the humerus. At this level, the distal epiphysis of the humerus, we may get different types of fracture, and we'll try to describe them one by one. The first fracture that will be at this level will be the supercondylian fractures. So the fracture site in the supercondylian fractures is that black line between the yellow part of this drawing, of course, the yellow part and the red part so it's in fact a fracture at the level of the distal metaphysis of the bone, and is usually displaced. The mechanism of fracture is the fall on the hand with the elbow in hyperextension, or a fall on the elbow when the elbow was in hyperflexion. So to this hyperextension or hyperflexion mechanism, which both of them are non-direct mechanisms, it may be associated a certain degree of abduction or adduction of the elbow. So that depends of the position of the upper limb at the moment of the trauma. Here is how it looks like. So the mechanism you can see here, the the person will fall on his hand with the elbow in hyperextension. That is the most frequent mechanism. So we can see here the aspect of the fracture site. The aspect of the fracture site is let's say, characteristic of the mechanism of the fracture. Whenever there is this hyperextension mechanism, the fracture site will be oblique from posterior to anterior and from proximal to distal. And here we have also an X-ray of such a fracture showing exactly the aspect of the fracture site. In opposition, when the mechanism will be by hyperflexion, then the fracture site will be also oblique, but this time it will be oblique from proximal to distal, but from anterior to posterior. So, in other words, looking at the X-ray of such a fracture, we can recognize the mechanism of the fracture at that moment. There is also, in terms of clinical examination, certain bone landmarks that we can determine in order to make the differential diagnosis between fractures at this level and dislocation of the elbow. We'll see in the lecture about dislocations. We'll come back to this slide and recall these landmarks that may make the difference between the two pathological findings. So here is what I'm talking about. With the elbow in 90 degrees flexion, the tip of the olecranon, the medial epicondyle and the lateral epicondyle may form a triangle with equal lines. So it's a equilateral triangle. When we have a dislocation of the elbow, this equilateral triangle will not be like this, and all these parts of the triangle will be different in size. And also, with the elbow in complete extension, the same three bone landmarks will be on the same line. So they will form a line, and when we have a dislocation, this line may be interrupted and will be in between these parts of the line, will get an angle. So these bone landmarks are very, let's say, logical if we explain them, but practically, when we examine a patient at the emergency room and the patient has a swollen elbow, then it will be very difficult to determine these landmarks. So from the semiological point of view, they are okay with physical examination, but like I said, from the practical point of view, they are not of very much help. But anyway, I'll mention them to you in order to be known. Also, we'll have to examine the radial pulse and the sensitivity and mobility of the hand of that upper limb. Treatment of these fractures is in most situations orthopedic. That's first of all, that's because these fractures occur mainly in, let's say, children and teenagers. So these categories of patients have thick periosteum and have a very high regenerative possibilities at the level of the bone. So that's why in the orthopedic treatment, usually 90–95% of these fractures will lead to union, so they will heal. That's why we prefer this treatment. But of course, this treatment must first of all provide the reduction of the fracture. Well, reduction may be done by external maneuvers, like you can see in this slide. There is something we need to do in order to obtain a good reduction. We put the elbow on that side in hyperflexion. You can see here, we put the elbow in hyperflexion. Ideally, we would like to immobilize the elbow after that in this position, but that's not possible, because as long as we try to immobilize the elbow in hyperflexion, then we'll get a compression at the level of the brachial artery, which will compromise the blood flow at the level of the forearm and the hand. So we cannot do that. But for reduction, we'll put this elbow in hyperflexion, because in this position, the triceps muscle will be stretched and will align the fragments. So this stretched muscle will make will act like a natural splint that will align the fracture fragments. And in this situation of good reduction, in order not to lose this reduction after we release this flexion, we prefer to introduce through the fracture side 2K wires, like you can see here. In 2K wires in figure X position, in letter X position, or two parallel K wires in order to stabilize the fracture site. So here is an X-ray of such after such a maneuvers. So we introduce these two K wires, and after that we can release this hyperflexion of the elbow in a 90 degrees position, in a position that we usually prefer to immobilize the elbow. So this will provide the stabilization of the fracture site and will not allow the secondary displacement of the fracture. If this reduction by external maneuvers is not possible, because it may happen like this also, then we need to go for an open reduction and a fixation by using a special plate which follows the shape of the bone, and that will be fixed to the fragments by using at least 3 screws in every fragment. Well, the principle of this fixation is to obtain a solid fixation which will allow the starting of physical rehabilitation the next day after surgery. The sooner we start the physical rehabilitation, the better will be the results in terms of recovery of the range of motion and the muscle strength. Here are some X-rays. We may use, like I said, a plate which follows the shape of the bone, or sometimes we may use an Y-shaped plate like this one with 2 branches fixed also with screws towards every epicondyle of the humerus. Complications which accompany this fracture may be like the opening of the fracture site. You can see here that especially the proximal fragment may be very sharp, and sometimes this sharp fragment may impinge and in fact pin the skin and be responsible for an open fracture. Also, we may get a compression at the level of the brachial artery, which may compromise the blood flow of the upper lip. Other complications may be like infection, especially in case of an open fracture, and also the Volkmann syndrome, which is, I will explain it immediately, what a Volkmann syndrome means, but I can tell you from the very beginning that the Volkmann syndrome means that the pressure will increase very much at the level of the fracture site, and that will compress over the vessels. So, and that will also may compromise the blood flow at the level of the upper limb. I will explain that in more details immediately. Other complications may be like late complications, like the bad union and the periarticular ossification, which are peculiar to the elbow joint. Other fractures at this level will be the super and intercondylian fractures. Well, all of them have the term of condylian fractures, but uh, like the previous fractures, which were only supercondylian fractures, were extra-articular fractures, so they didn't involve the articular surface of the humerus. Uh, these fractures, this time super and intercondylian fractures, they usually have at least one fracture line that crosses the articular surface, like you can see here in this drawing. The aspect of the fracture line may be T, Y, or V when we have only three fragments, or we may have a comminuted fracture like this one on the right side, when we may get, uh, let's say, about 10 or 15 fragments, some of them being very small, which will compromise the normal anatomy of the articular surface. And we'll see in treatment that the goal of our treatment will be to restore the normal anatomy of this articular surface. So this one is an articular fracture. Same thing, it's a classification you don't need to remember. This one here, it shows only that the fracture may be quite comminuted sometimes and makes a very difficult restoration of the articular surface. Here is an X-ray of such a fracture. At clinical examination, the elbow will be swelled, of course, in comparison with the other one. Uh, the arm will be shortened if we measure the distance between the acromion and the lateral epicondyle in comparison with the other side. The elbow will have abnormal mobility, meaning that, the elbow is a joint that allows only flexion and extension. Uh, in this case, the elbow will allow also valgus and varus movements, which are abnormal. These are due to the presence of these fractures, of this super and intercondylian fracture. And also, we need to accompany our examination by a vascular and neurological peripheral examination. This time, the treatment of these fractures is mandatory to be surgical. I've mentioned that when we have presented you the general principles in fractures, that articular fractures must be treated surgically, because the goal of the treatment is to restore the integrity of the articular surface. So the golden standard for these fractures will be the uh, uh, reduction, the anatomical reduction and solid fixation, in order to allow the immediate starting of the physical rehabilitation. And the most used technique for this type of fractures is by cutting the olecranon. So the approach needed to see the articular surface of the distal humerus will be by cutting the olecranon, like you can see here. Then uh, we bend the olecranon in order to see the articular surface of the humerus and do the surgery on the humerus, which consists in restoring of the articular surface. You can see here. So it's like a puzzle game, especially in the situations when we have a comminuted fractures. It will be quite difficult to identify all the fragments, put them back in place, and then fix them by using K-wires and screws. So the main goal, like I said, will be to restore the articular surface. And then we have to reattach the articular surface to the rest of the humerus by using a plate, or better, using two plates like you can see here, in order to obtain a solid fixation. So, and after we fix the fracture, we go back and reattach the olecranon by using two K wires and a wire loop of the figure 8. So we'll see this type of osteosynthesis also in olecranon fractures. So this is the way of fixation. The drawing you can see on the right side is also a possibility, but using only these two screws will be insufficient in terms of fixation, and that will not allow the immediate physical rehabilitation of the elbow joint. Complications of these fractures may be like the open fracture, vascular complications at the level of the brachial artery, infection of the fracture site, and Volkmann syndrome again. I'll come back to the Volkmann syndrome. And late complication may be the bed union and the periarticular ossification. Well, the elbow may be submitted to this peculiar complication, which is called periarticular ossification. This occurs usually after a time of immobilization when we start the physical rehabilitation. Uh, it's a complication, the etiology, the precise etiology of this complication is not very well known yet. Uh, because due to unknown reasons, when we start the rehabilitation of the elbow after immobilization, some very small hemorrhagic points will occur in the soft tissues around the joint. And these small bleedings around the joint will initiate some ossification points, which will develop, will grow, and finally will impinge over the joint and will diminish substantially the range of motion at the level of the elbow. So this complication can be avoided by starting the physical rehabilitation very gentle, not by very brutal maneuvers, in order to avoid this bleeding at the level of the soft tissues. Also, the insufficiency of the reduction of the fracture, meaning not a perfect restoration of the anatomy of the articular surface, may lead also may lead also to osteoarthritis of the elbow, which of course by being painful will be very disabling for the patient. So by all means, that's what I want to emphasize, by all means in such a fracture we need to obtain an anatomical reduction of the articular surface in order to have long-term good results. Other fracture of this level will be the fracture of the medial epicondyle. So at the level of the medial epicondyle, we have a conjoint tendon, the origin of a conjoint tendon of the muscles from the anterior aspect of the forearm. So the pronators and the flexors of the hand and of the fingers have this conjoint tendon which will as the origin of the medial epicondyle. The mechanism of this fracture is usually non-direct by a fall on the hand with the elbow in hyperextension and with a forced valgus mechanism. This forced valgus mechanism will uh, pull over this fragment over this medial epicondyle and will detach it from its normal position. These fractures may be non-displaced fracture, which is quite rare, unfortunately, or displaced fractures, which is the normal situation. You know from anatomy also, this is an X-ray of this fracture, like you can see here. This is a non-displaced fracture, and you know also from anatomy that on the posterior aspect of the medial epicondyle we have the ulnar nerve. So when we have this type of fracture, this type of fracture may be accompanied by lesions at the level of the ulnar nerve, and we may get palsies of this level. In this situation, the patient being unable to do the abduction and adduction of the fingers. So the abduction and adduction of the fingers is done by the interosseous muscles, like you probably also remember from anatomy, and the interosseous muscles are innervated by the ulnar nerve. So that's the maneuver through which we can diagnose the lesions at the level of the ulnar nerve. Also, the patient, of course, will have pain at the level of the medial epicondyle. But like I said, in most situations, the fracture is displaced and the fragment may even penetrate into the elbow joint, like we can see in this X-ray. Due to this fragment into the elbow joint, the movements of the elbow joint will be blocked, so it will be much diminished. And in these situations, we need to get out the fragment from the joint and fix it in order to restore the function of the elbow joint. Also, in these situations, we have an abnormal mobility of the elbow by being possible that this makes possible to mobilize the elbow in valgus and varus position, which is not normally possible. Sorry for the break. I had to get rid of some people aggressing me in my office. Okay, I'm joking, of course, but they try to enter. Yeah, okay. So we have this abnormal mobility of the elbow joint due to the fracture of this epicondyle, which will make possible this mobility. Okay, like I said, if the fracture is displaced, then we need to go for the open reduction and fixation. Open reduction, of course, by going into the fracture site, and then we fix the fragment back in its place by using a screw, usually, if the fragment is big enough, like we can see here. If the fragment is small, so it will not allow a screw, then we can remove the fragment and reattach the conjoint tendon to the bone by using non-absorbable sutures. And also, this must be whatever fixation with screw or removal of the fragment would be, it must be accompanied by a release at the level of the ulnar nerve in order not to be incorporated in the callus. The same mechanism that I have described for the humeral shaft fractures. Other fractures may be at the level of the humeral capitulum. See, the capitulum is this small part of the humerus which is in contact with the radial head. This small joint, this, let's say, yes, this small joint, which is part of the elbow joint, is responsible of the pronasupination of the forearm on the humerus. And sometimes by the same mechanism of falling on the hand, with the elbow in hyperextension, we may get a fracture of this fragment. It's also an articular fracture, and the capitulum may become also like a loose body inside the elbow joint. This fracture may involve even a bigger fragment, not only the capitulum, the whole lateral condyle of the humerus may be involved in this, so it may be also displaced due to the traction of the ligament with the lateral ligament and the lateral conjoint tendon, which is inserted on this part of the humerus. So these fractures are all of them articular and displaced. Of course, the symptoms of the lateral condyle will be on the lateral aspect of the elbow. Before I told you that the symptoms for the medial epicondyle were on the medial part of the elbow. So it means pain and pain at the level of the elbow. So lateral or medial are at the time of clinical examination a good sign for orientation if the fracture is on the medial or on the lateral aspect. The patient has also physical disability and abnormal mobility in the frontal plane. Well, all these are more or less general signs for fractures at the level of the elbow joint. Like any articular fracture, this must be treated by surgery. So we need to reduce the fracture, put the fragment back in place, and then fix it with two screws, at least two screws, in order to prevent the rotation of the fragment. We may even use sometimes even some K wires, some small K wires. And in addition, if the fixation with screws is not enough. So you can see this thing better here on this more magnified drawing. If we have a fracture of the lateral condyle, a bigger fragment, then we need to reduce it, of course, and then fix it with at least two screws oriented in different directions in order to obtain a good fixation. Or we may even sometimes use a plate with screws fixed at the two at this towards the metaphysis of the bone, and also at the level of the metaphysis of the epiphysis of the bone. So the solid fixation will provide, let's say, a better rehabilitation, physical rehabilitation, and a better result in terms of restoring the range of motion. What is the Volkmann syndrome? I have told you that I will explain a bit about the Volkmann syndrome, which is a very feared complication of fractures of the upper limb. The Volkmann syndrome is in fact a peripheral acute ischemia syndrome. So it is due to the interruption of the arterial blood flow towards the extremity of the limb. And this is done usually due to a compression at the level of the arteries, a lesion of the artery, or a thrombosis. A thrombosis inside the artery, meaning that the blood flow will be diminished or completely interrupted. So these complications in orthopedic is usually due to the hematoma, which occurs at the level of a fracture and which accompanies the fracture. The signs of this syndrome are multiple, but I can tell you that the only sign that is useful in diagnosis will be the paresthesia. You know, when this syndrome is at the beginning, when the blood flow is interrupted at the beginning, then the patient will have some paresthesias, which are which must orient the patient to go to the hospital immediately. Whenever we put the upper limb in a cast, or whenever we release the patient from the hospital after a surgery at the level of the upper limb, we must prevent him that if in the next days he'll have paresthesias, then he must immediately come to the hospital because he or she might get Volkmann syndrome. Well, in this situation, all the signs that are here, even if they are in the Romanian language, like pale skin, uh, pain at the level of the forearm, no pulse at the radial artery, loss of mobility of the fingers, and lower of the skin temperature. All these signs are not useful because they are very late signs. So the only sign that will make possible our treatment for this syndrome are only the paresthesias, because all the other signs, when they occur, it means that already the ischemic lesions already exist. So, and they are non-reversible, like they are when we get the patient in the first stage of this complication, when it displays only paresthesias. That's a method to determine this syndrome by measuring the pressure of the level of the compartments of the forearm. You must remember from anatomy that at the level of the forearm we have three muscle compartments: the anterior compartment, the lateral compartment, and the posterior compartment. So all these compartments that contain, of course, muscles are covered by fascias. The fascias are inextensible structures. So whenever the pressure grows inside the compartment, then the wall of the arteries will be compressed and the diameter of the vessel will be diminished. The consequence will be in diminishing of the blood flow at the level of that artery. That can be measured by punctioning the compartment. So we puncture the compartment and we measure the pressure in millimeters, of course, exactly like we measure the blood pressure. Yeah. So usually the diastolic pressure is about 70 millimeters. If this will grow with 10 to 30 millimeters, we must survey the patient, or if it grows with 4 to 45 millimeters, then we must to take the patient to the operating room, do the so-called fasciotomies. So we have to incise the fascias in all the three compartments in order to allow the wall of the blood vessels to re-expand and to restore the blood flow at the level of the forearm. So it's a very tricky complication because the consequences of these complications are very disabling, because we can see here that will be what will happen if we don't diagnose in time these complications, and also we don't do whatever needed. We'll get a fixed hand with the fingers like a claw, like a paw, whatever, yeah, which will be completely unfunctional, and that usually will involve the responsibility of the physician, because it is usually due to cast immobilization or insufficient surveillance of the post-operative days after surgery. So this Folkman syndrome, like I said, it's a very feared complication and must be very carefully looked after. Let's go to the forearm, the bones of the forearm. You know, the forearm has two bones. There are the radius and the ulna, and the main function, generally speaking, the main function of the forearm is pronosupination. So these two bones are able to rotate one to another, providing the pronosupination, which is so useful for the function of the hand. Okay, let's describe the fractures at this level. The fracture of the proximal epiphysis of the ulna, which is called the olecranon, you can see here this drawing. The olecranon fractures usually occur by falling from the same level on the elbow. Usually these fragments are displaced, and you'll see a gap in between bones. That's due to the traction of the olecranon by the triceps muscle. The triceps muscle will pull over this fragment and will get this displaced intra-articular fracture. These fractures, due to the fact that they are intra-articular, they must be also operated. So we need to perform this open reduction, like you can see here, and fixation by using this plate with screws. It has a special shape, this plate, in order to allow the introduction of this screw at the level of the olecranon. So after reduction, we use this screw, this special plate, or more often, we prefer to use these two K wires combined with this figure 8 wire loop. These two K wires combined with this figure 8 wire loop is a very useful mean of fixation for the olecranon, because it has the capability of transforming the shearing forces into compression forces. So we can allow the patient to start the physical rehabilitation the next day after surgery. And these compression forces will be very favorable to union of the bone. You know that always compression forces are favorable for the union, and shearing forces are unfavorable for the union of the bone. Here is an X-ray, post-operative X-ray. You can see here this type of fixation, which is the golden standard for the olecranon. The plate, which I presented before, is used only in cases of comminuted fractures, when very unstable fractures, when we need to restore the articular surface of the olecranon by putting all these fragments, all that small fragments together. Also, at the level of the elbow, we may get fractures of the proximal extremity of the radius this time. The proximal extremity of the radius is called the radial head. The radial head may get simple fractures, like we can see here, non-displaced simple fracture, a displaced simple fracture, or a comminuted fracture. These fractures are also intra-articular because they involve the articular surface of the radial head. There is a classification system here described by Mason. It has three types of fractures, like you can see in this slide. Type 1 is, like I said, the non-displaced simple fracture. Type 2, displaced simple fracture. And type 3, comminuted fracture. Here is an X-ray. We can see here this fragment, small fragment, which is displaced. So that one is a type 2 Mason fracture. And here we can see a type 3 Mason fracture with small multiple fragments. So it's a comminuted fracture which has destroyed in fact the whole radial head. Well, all these fractures except the type 1 Mason fracture, which is non-displaced, must be treated by surgery, because like I said before, we need to restore the shape of the articular surface. Here is a type 2 fracture where the fragment was put back in place and was fixed by using two screws, two small screws. There are special instruments and special implants for such type of small fractures. They are called mini osteosynthesis, and they are able to fix the small fragments in place after a previous reduction. In type 3 Mason fractures, the comminuted fractures, we usually have very many fragments, and even if we try hard to restore the shape of the articular surface, we will be unable to do it. So in this situation, we need to resect the radial head. So it's better to resect the radial head instead of leaving in place an insufficiently reduced radial head, because that one will lead to osteoarthritis, while if we eliminate the contact between the radius and the humerus by resecting the radial head, will provide a mobile and painless elbow. So again, in these type 3 fractures, we prefer to do the resection of the radial head. Also, at the level of the forearm, we may have fractures of the diaphyses of the bones, of the two bones, the ulna and the radius. We may get isolated fractures of the diaphyses, like we can see here. In this case, in this X-ray here, A with this A X-ray in the middle, we see a fracture of the radial diaphysis, a displaced fracture of the radial diaphysis. These fractures may be isolated, or we'll see in the next slide, they may be accompanied, I mean this fracture may be accompanied by a dislocation at the level of the distal radial ulnar joint. This association between this dislocation and the diaphysis fracture is called fracture dislocation of Galeazzi, because it was described by Galeazzi. The same thing may happen at the diaphysis of the ulna. We may get isolated fractures of the ulna, like we can see here, or it may be accompanied by a dislocation of the radial head, and this one is called the fracture dislocation described by Monteggia. So I want to emphasize here one thing. Whenever a patient comes to the emergency room with suspicion of fractures of the diaphysis of the forearm bones, we need to take an X-ray which must include both neighborhood joints, elbow joint and the wrist joint, because otherwise, if we perform a limited X-ray only at the level of the trauma, we may not detect this associated joint complication that may compromise our late results of the treatment. So all these fractures must be operated. I have also to get back to anatomy for 1 second. Like I said, the forearm is specialized in pronosupination, and which is the mechanism in fact. The radius is that one that surrounds the ulna. So the ulna is the fixed part of the pronosupination, while the radius will be the mobile part which will go around the ulna. Also in this drawing we can see that in the proximal part of the forearm we have mostly supinatory muscles, and in the distal part we have mostly pronation muscles. So that's why during these fractures we always get rotational displacement of the diaphysis, meaning that the proximal part will go in a direction of supination, and the distal part goes in a direction of pronation. So that's why all these fractures must be treated by surgical method, because we cannot achieve the reduction of the radius, especially by external maneuvers. That will be impossible. So the only way to treat these patients will be by open reduction and fixation with plate and screws. You can see here the type of displacement of the rotational displacement of the fractures that cannot be solved only by surgery. So the golden standard, you can see here, there are plates with screws, at least through 3 screws in every fragment after an anatomical reduction. If you remember from anatomy, the radius is not straight. The ulna is more or less straight, but the radius is an S-shaped in order to allow its rotation around the ulna. So during reduction of the radius, we need to restore this S-shaped of the bone in order to restore the whole degree of pronosupination. And of course, fixation with these plates and screws. So, to summarize about the forearm, in adults, the only treatment, so 100% of the adult patients with fractures of the diaphysis of the two bones must be operated. So the only treatment must be the surgical treatment by open reduction and plate and screws. There is no orthopedic treatment. And here is the only situation of an orthopedic treatment, but this time only in children, so not in adults. In children, because they have a very thick periosteum, then we can perform a close reduction, by following the way back the mechanism of the fracture, so we can reduce it by external maneuvers like we can see here, and then put it in a cast, and then we may obtain the proper reduction and union of the bone, but only in children. Complications may be like bad union. Here are the complications. The immediate complications will be like open fracture, vascular lesion, and Volkmann syndrome I have already mentioned. And late complications may be bad union and non-union, which usually is due to insufficient fixation. Okay, let's go to the distal epiphysis of the radius. The distal epiphysis of the radius may have different types of fracture lines. And you can see here, it's a table with the most frequent types of fracture of the level of the distal epiphysis. We must see, first of all, this second image, which will show us the extra-articular displaced distal radius epiphysis fracture, which is the most frequent fracture in orthopedics and is called Puteaux-Coles fracture. Well, in the French literature, you will probably literature, you will find it probably only as Coles fracture. But in fact, these two authors had equal contributions in the description of this fracture. So we call it the Puteaux-Coles fracture, which is, like I said, an extra-articular fracture, you can see here, in comparison with most of the others, which are intra-articular fractures. So this one, this Puteaux-Coles fracture, like I said, is the most frequent fracture, and its main mechanism is the fall from the same level on the hand with the wrist in a position of hyperextension. And in this position, the fracture line is at the level of the distal metaphysis of the bone, and is a displaced fracture, like you can see here in this X-ray. The distal fragment, or in other words, the epiphysis fragment, is displaced proximally, posteriorly. We have a better image here. So here is the better image. So the distal epiphysis is displaced posteriorly. It is ascended, so is displaced proximally, and also it is uh, uh, displaced laterally. So in this type of fracture, we have in fact three types of displacement: proximally, posteriorly, and laterally. And this will uh, modify the anatomy of the wrist joint. Because from anatomy, you must also remember that the radial styloid goes more distally than the ulnar styloid. And that makes an oblique line that makes possible the ulnar tilt of the hand. Our most activities that we usually do are with the hand in an ulnar tilt position. That is the physiological position of the hand. This is possible only to this, let's say, anatomical detail that the radial styloid goes more distally than the ulnar styloid. But in this fracture, when the whole epiphysis is ascended, then the two styloids will go to the same level. So this oblique line will become horizontal and the hand will be tilted in a radial position, which is not physiological. So these fractures, like I said, are very frequent. If you would have been in your orthopedic training during the winter time, you could have seen at the emergency room about 40 to 50 such fractures in 24 hours. Because, like I said, it's very frequent, especially in old people who are also who have also osteoporosis, so have weaker bones. And in these persons, you could have seen very many such fractures at the emergency room. So they are the most frequent. The treatment of this fracture is by, here is the aspect of the hand and of the wrist in such a fracture. No, is a lateral displacement and posterior displacement of the distal epiphysis. These fractures are treated by orthopedic treatment. I won't go into details about the treatment because this topic especially will be detailed by one of our assistants during the practical presentations. So you'll see then that the treatment consists in close reduction and immobilization in a cast. The problem is with these fractures that they are very unstable. I mean, they are very easy to reduce, but very difficult to maintain by casting. So we have imagined, or let's say, have been imagined some less invasive methods that can prevent the secondary displacement of a fracture. Like, for example, this pinning. After reduction, we introduce this pinning through the ulna into the radius in order to fix, to secure our reduction. These pins will be removed after 6 weeks in order to start the physical rehabilitation. Or we can introduce some pins through the fracture site, reduce the fracture by levering these pins, and then introduce them in the second cortex in order to fix the fracture. This method of Kapanji, described by Kapanji, is not only a fixation method, but a reduction and fixation method. So these are less invasive methods that may provide better maintenance of our reduction. Because if we will not maintain it, then we'll get this bad union that you can see here with the X-ray, of course, with the articular surface tilted exactly in the opposite position, so that one faces dorsally. The styloid is ascended. You can see that the level is, the line in between them is horizontal, and the hand will be tilted in a radial position, which is not functional. This situation can be corrected only by surgery, of course, cutting again the bone, reorient the distal epiphysis, and then fix it with a plate and screws, like you can see here. The same fixation method will be indicated for the articular fractures. You remember that table with all kinds of fractures that I have presented you at the beginning of this type of fractures? All those articular fractures must be reduced by open reduction and fixed with a plate and screws of this type, because, like I said, they are articular fracture. There are some situations when we have a comminuted fracture. And in these comminuted fractures, the anatomical reduction will be quite impossible, exactly like we mentioned for the radial head. And in these situations, we prefer to use an external fixator, like you can see here, and put a traction over the upper limb so that the shape of the articular surface of the carpal bone will reshape the distal epiphysis of the radius, which are, complementary in shape, and will make a progressive good reduction of this. Going more distally, we must talk about the scaphoid bone fractures. The scaphoid is one of the 8 scaphoid bones. The carpal bone, sorry. So scaphoid is one of the 8 carpal bones. The scaphoid bone is peculiar by the fact that it's covered 90% of its surface by articular cartilage. And the only blood supply it gets is from his distal end. So whatever is proximal by fracture to this blood supply will undergo necrosis. The mechanism is also by an hyperextension at the level of the wrist joint, when the posterior margin of the radius will hit the carpal bone, the scaphoid, and will fracture it. Here are some x-rays. The x-ray should be taken in the so-called writing position. So we put the hand of the patient on the X-ray table exactly in the position like he or she would want to write something. So that's called in the writing position. In fact, is a 3/4 view. It's not AP, not lateral view. It's a 3/4 view, which will display better the whole scaphoid bone and will show us the fracture. And the fracture is like you can see here. Here is the fracture line. This fracture line may be more visible after 2 or 3 days after the fracture, because the pathological osteoporosis will be installed at the level of the fracture level. These fractures may be treated by orthopedic methods, by immobilization in a cast, only in the non-displaced fractures. Then they can be immobilized in such a cast for about 6 weeks. After that, we perform an X-ray, and if there are signs of union, we continue the immobilization for another 6 weeks. So achieving the union of this bone is very difficult due to the fact that one bone fragment has blood supply and the other one doesn't. So it's very difficult for the physiopathological mechanism to act for the union of the bone. If the fracture is displaced, or we could not obtain the union by orthopedic methods, then we need to operate the patient and perform an open reduction and fixation with a screw, a compression screw, which will compress the two fragments one to another. Even like this, sometimes we'll not obtain the union, and then we may need to bring some graft at the level of the fracture. We will harvest a small piece of graft from the level of the radial styloid and then apply it at the level of the fracture site in a special groove in order to bring cancellous bone at the level of the fracture and reinitiate the union process. So doesn't matter that this bone is so small, it may provide big problems in union, and the patient may get a painful wrist due to the lack of union of this bone, due to the non-union of this bone. And finally, one fracture I want to mention is the fracture of the basis of the first metacarpal bone of the hand. So this is an articular fracture, and a small fragment from the basis of the metacarpal bone, first metacarpal bone, will be detached, and this fracture will be accompanied by the dislocation of the basis of this metacarpal bone. This fracture is called the boxer's fracture because it's very frequent in people practicing this sport. Being an articular fracture, it should undergo reduction, so we can perform a close reduction, like we can see here, putting the first finger in an abduction position. So first of all, we need to reduce the dislocation of the first finger to the carpal bones. We do this by external maneuvers, and also we will reduce the small fragment. From now on, we have two choices. We'll put the wrist in a in a cast, like we can see here, and wait for the cast to finish drying, so to be strong in this position. Or the better choice would be to fix this metacarpal bone after reduction in this position by using two K-wires. These K-wires may be introduced from the first metacarpal bone to the second metacarpal bone, or like you can see in the first drawing here, we will introduce this K-wire through the first metacarpal bone into the trapezius bone. This fixation will be temporary for about 6 weeks until we obtain a union of the basis, or let's say a primitive union of the small fragment at the basis of the metacarpal bone. Then we remove the K-wires and the patient can start the physical rehabilitation. Here is an X-ray after such a surgery showing the K-wire which was introduced in the two bones. Okay, we finished this one today. Tomorrow you will start the fractures of the lower limb with Dr. Badilla, and probably we'll see each other again on Friday for dislocations. Okay.
Thank you.
You're welcome.
Okay, thank you so much.
Thank you.
Thank you.
You're welcome. Bye-bye.
Thank you, Doctor. Bye.
Thank you.